Prostate active surveillance, workup, AUA, ASTRO, SUO criteria, the preferred treatment for all very low risk disease and low risk disease. Treatment may be offered for low risk, especially if the life expectancy is greater than 10 years. Active surveillance protocol can also be done in favorable intermediate risk, may also observe any intermediate risk if the patient is age 75 or up. Large retrospective studies have now shown risk is not increased in black men. Treatment for active surveillance, PSA every 3 to 6 months, DRE every 12 months, biopsy within 6 to 12 months with anterior directed cores, then serial biopsy every 2 to 5 years. MRI may be used. If there's a rising PSA and the biopsy is negative, then do an MRI on suspicion of anterior lesion, then biopsy. Progression is a new Gleason score 7 or greater or significant increase in the disease volume. Things here for outcomes. Chance of metastasis on active surveillance is 1.5% per PROTECT and 3% per Sunnybrook and clots. There's a 1% chance of dying with prostate cancer. Those still on surveillance, 10 years, 65%, and 15 years, 55%. Very low risk prostate cancer is defined as T1C, Gleason grade group 1, a PSA of less than 10, less than 3 cores with less than or equal to 50% in each core, a PSA density of less than 0.15 nanograms per milliliter per gram. The treatment for this is active surveillance. In terms of outcomes, 15-year cause-specific survival is 99.9%. Grade increase happens in 25% of patients. Prostate SBRT, MRI, eligibility, low to high risk groups, although there's low evidence for T4 disease, or oligometastatic disease. You treat the mets and also the primary tumor. One published series has shown safety with prior TERP. High AUA is generally not viewed as a contraindication. Treatment is 36-25 in 5 fractions, 725 centigrade per fraction, up to 40 gray in 5 fractions, which is what MSKCC does. Other regimens include 42.7 gray in 7 fractions, which is the hypo-RT-PC protocol, or 36 gray in 6 fractions once weekly, which is Stampede. You treat every other day, twice weekly, or once weekly. In terms of your CT simulation, supine, VAC-lock, at least 6 fiducials need to be placed, 1 in the apex of the prostate, 1 in the base, 2 on each side. Drink 12 ounces of water 30 to 60 minutes prior to SIM, MRI and each treatment, and empty rectum. Fuse fiducials on the MRI and CT. MRI with VAC-lock is ideal. CT on rails is an option if no fiducials. Dose, again, is 36.25 to 40 gray in 5 fractions. Other would be 42.7 gray in 7 fractions, which is an IMRT but not an SBRT plan. Field should be the prostate only. Do not add nodes. Consider adding proximal seminal vesicles for intermediate risk, and for high risk, either proximal seminal vesicles or the entire seminal vesicles. PTV should be 5 millimeters, 3 to 5 millimeters posteriorly. Chemo is ADT per risk. Dosimetry, NRG GU005. The rectum, D0.03 cc's is less than 38.06 gray. A variation acceptable is less than 40 gray. D3 cc's is less than 34.4 gray. Variation of less than 40. D10% is less than 32.63. VA less than 34. D20% is less than 29. VA of less than 30. D50% less than 18.13, VA less than 19. Again, this is the rectum. One more time, D0.03, cc's less than 38.06, D3 cc's less than 34.4, D10% less than 32.63, D20% less than 29, D50% less than 18.13. Bladder, D0.03 cc's less than 38.06, D40% less than 18.13. Urethra, D0.03 less than 38.78. Recommended but not required. Penile bulb, D0.03 cc's less than 100%. D3 cc's less than 19.9 gray. MSKCC phase 1 dose escalation, average PTV D95 within 95 to 101%, average PTV D98 within 89 to 100%, 3 mm rectal wall max less than 103%, D1cc less than 38.5 gray. Follow-up, a PSA bounce can occur in about 25% of patients to mean 0.75 up to several years later. Outcomes for low risk, 95 to 99%, intermediate risk, 85%. Low-risk prostate treatment, do an H&P, past medical history of cardiac disease, myocardial infarction, diabetes, osteoporosis, osteopenia, TERP, get a full history, AUA, sexual history inventory, labs, PSA, CBC, CMP. Imaging, some institutions may obtain an MRI to evaluate the prostate. No staging scans are required for low-risk disease. Genetic molecular testing, considered Decipher, Oncotype DX prostate, Prolaris, or Promark. Treatment, active surveillance, preferred per AUA 2017 guidelines for low-risk prostate cancer. Treatment may be offered. Risks are not increased in black men. Hypofractionation protocols include 60 gray and 20 fractions, 3 gray per fraction, which is profit, chip, similar in NCI Rome. Alternatively, 70 gray and 28 fractions at 2.5 gray per fraction per RTOG 0415. Conventional fractionation is 78 gray in 1.8 gray per fraction or 2 gray per fraction. SIB boost is 95 gray to a nodule, 77 gray to the prostate in 35 fractions, and SPRT is 35 to 40 gray in 5 fractions. For SIM for low-risk prostate, place 3 fiducial markers in different planes and SIM after at least 1 week from the fiducial placement. You may use daily cone beam CT and no fiducials. SIM should be supine, VAC-lock, full bladder, and empty rectum. Optional include rectal balloon or hydrogel spacer. IGRT should be daily port films for fiducials or daily cone beam CT. Again, dose hypofractionation is 60 gray and 20 fractions at 3 gray per fraction, or 70 gray and 28 fractions at 2.5 gray per fraction. An SIB boost would be 95 gray to the nodule and 35 fractions with 77 gray to the prostate SIB. SBRT is anywhere between 35 and 40 gray in 5 fractions, and conventional is 75.6 to 80 gray in 1.8 or 2 gray fractions. The field is the prostate plus 6 to 8 millimeters PTV margin in all directions, except for 5 millimeters posteriorly for the PTV. Dosimetry. Some stricter rectal constraints may require less PTV or lower coverage posteriorly or spacor to achieve. Hypofractionated protocol per chip, 60 gray and 20 fractions. The rectum V20 is less than 85%. Rectum V30 is less than 57%. Rectum V40 less than 38%. Rectum V50 less than 22%. Rectum V60 less than 0.01%. Bladder V60 less than 5%. V48.6 less than 25%. V40.8 less than 50%. Conventional, strict UK Sweden is the preferred. This is rectum V75 less than 3%, V70 less than 15%, V65 less than 30%. The V75 is feasible with ARCs and or spacor. RTOG can be considered variations acceptable. Notes, the profit dose constraints are shown here. These use organ wall rather than whole organ. Chip constraints seem preferred since they have been updated based on retrospective clinical outcomes. Follow-up, PSA bounce may occur. This is much more common in Gleason 6 in younger patients. It occurs in 15 to 30%, usually at about 16 to 24 months, as late as 36 months, with a rise in PSA of 0.2 to 1 and a decrease to nadir or below by 1 year. Many reports say it is a positive prognostic factor, and some no change or worse. A PSA failure typically happens later at about 30 to 36 months. A PSA bounce is greater than 0.2, then return to nadir. PSA failure is greater than or equal to 2.0 nanograms per milliliter above the nadir. In the PSMA PET era, failure may be able to be detected prior to a PSA of 2.0, considered for high-risk patients. For low-risk prostate, the biochemical freedom from failure-free survival at 5 years is 90 to 99%. Cause-specific survival is 99%. Hypofractionated, there's no difference in biochemical failure or late toxicity on a Swiss meta-analysis. Acute GI slightly increased, may vary by regimen. Adverse effects: acute fatigue, urinary frequency, obstructive symptoms, dysuria, rectal frequency. Dysuria and bowel changes typically return to normal in 1 year. Proctitis, loose stools. Late side effects include radiation proctitis. Rectal bleeding occurs in 9% and is bothersome in 2.6%. Fistula, perforation, urethral stricture in less than 1%, and erectile dysfunction in less than 30%. You manage urinary symptoms with alpha blockers, NSAIDs, and pyridium. Intermediate risk prostate cancer, you have a workup as above and includes staging for unfavorable intermediate risk. For T2 and greater than 10 PSA, do a bone scan. Pelvic CT if the nomogram indicates the chance of nodal involvement is greater than 10%. Again, genetic molecular testing, consider Decipher, Oncotype DX, Prostate, Prolaris, and Promark. Treatment for intermediate risk prostate includes hypofractionated or conventional radiation. Consider 6 months of adjuvant ADT for unfavorable intermediate risk disease. Check comorbidities. Again, hypofractionated treatment includes 60 gray and 20 fractions at 3 gray per fraction. Profit chip similar in NCI Rome, or 70 gray and 28 fractions at 2.5 gray per fraction. Conventional would be 78 gray and 1.8 or 2 gray per fraction. An SIB boost would be 95 gray to the nodule, 77 gray to the prostate, and 35 fractions. SIM, see above. Hypofractionated is the same as above. Intermediate risk field is prostate plus 6 millimeters to 8 millimeters PTV margin in all directions, except for 5 millimeters posteriorly for the PTV. Some include 1 centimeters of the seminal vesicles for intermediate risk. Chemotherapy, favorable, no ADT, unfavorable, 6 months of adjuvant ADT per Dan Spratt. Lupron dose, Leuprolide is 7.5 milligrams for 1 month, 22.5 milligrams for 3 months, and 45 milligrams for 6 months. The dosimetry is as above. Timing, the ADT can start prior to or at the time of radiation. Notes the Roche formula, use is declining. ECE is 3/2 PSA plus 10 times the Gleason score minus 3. Seminal vesicle invasion is Gleason score minus 6 times 10 plus the PSA. Lymph node involvement is Gleason score minus 6 times 10 plus 2/3. Outcomes for intermediate risk prostate, there's a 75 to 90% biochemical failure-free survival at 5 years. An overall survival benefit with ADT is about 5 to 10%, 88% versus 78%, D'Amico and RTOG 9408, but without dose escalation. High-risk prostate cancer, as above, plus staging, CT or MRI, bone scan, PSMA, choline, 11, or flucyclovine PET. Avoid SBRT and T4 disease. Treatment should be 18 or 24 months. Plus 18 or 24 months of ADT first, plus hypofrac or conventional RT. Whole pelvic RT to 45 gray for lymph node risk greater than or equal to 20%. The hypofractionated protocols here are essentially the same, 60 gray and 20 fractions, 3 gray per fraction per profit chip, similar in NCI Rome. 70 gray and 28 fractions at 2.5 gray per fraction per RTOG 0415 with an option of an SIB 45 to 52 to nodes with 26 to 27 fractions. Or 68 gray and 25 fractions plus 50 gray whole pelvic RT, SIB per pop RT. Conventional would be 78 gray and 1.8 gray or 2 gray per fraction to the prostate only, with 45 gray to the prostate and seminal vesicles plus boost to prostate to 79.2 gray total. SIM is as above. We just went through this. In terms of the field for high-risk prostate, many include, for the prostate, 1 centimeter of seminal vesicles to a total dose. Some include the entire seminal vesicles, especially if higher risk are involved. Optional whole pelvic RT, common iliacs, start at L4 or L5, internal and external iliacs, presacral, obturator nodes. Add an extra 7 millimeter CTV margin around the vessels, then add an additional 7 to 8 millimeter PTV. PSMA mapping has shown that 25% of nodes spread to the para-aortic nodes. Some choose to include pelvis based on the Roche formula if the lymph node risk is greater than 15%. Others say that these overestimate the risk of involvement. Again, lymph node involvement would be Gleason score minus 6 times 10 plus 2/3 of the PSA. Seminal vesicle is Gleason score minus 6 times 10 plus the PSA. ECE is Gleason score minus 3 times 10 plus 3/2 of the PSA. Chemotherapy for high-risk prostate, 18 or 28 or 36 months. Total of Lupron. You can start adjuvant per Dan Spratt. Some physicians give bicalutamide 2 weeks prior to reduce the risk of potential flare from subclinical metastases. You can consider docetaxel, especially in Gleason 9 to 10 or very high-risk disease. Again, dosimetry is as above. Timing, ADT can start prior to or at the time of radiation. ADT recovery, short-term ADT, median time to testosterone recovery is 17 months. Long-term ADT, 12 months after 6 months of ADT, 3.6 years with 18 months of ADT, about 75% at 5 years, 6.6 years with 36 months of ADT. ADT improves overall survival and biochemical failure by about 10%. Biochemical progression-free survival for high-risk disease is 75 to 85%. DART study evaluated ADT with dose escalation and showed a benefit with ADT in high risk. 5-year biochemical progression-free survival is 90% and overall survival 95%. Adverse effects of high-risk prostate treatment. ADT side effects are, of course, hot flashes, loss of libido, fatigue, distant mets, hyperlipidemia. This should not be distant mets. This is diabetes mellitus, hyperlipidemia, obesity, and osteoporosis. Venlafaxine or Megace for hot flashes. Salvage prostate treatment. Workup, get an MRI, PSMA or Axemin PET. PSMA is the most accurate for salvage prostate treatment. It detects lesions in 38% and PSA of less than 0.5 nanograms per milliliter. Bone scan and CT abdomen pelvis if the MRI and PET are not available. Consider Decipher or Oncotype genetic testing. Indications for salvage prostate treatment include a PSA of greater than or equal to 0.2 plus other risk factors such as a positive margin, ECE, seminal vesicle invasion, or T4 disease, or greater than 0.1 to 0.5, or doubling time of less than 10 months per various sources. Note that adjuvant radiation has no benefit over early salvage RT and increases GU toxicity. Salvage radiation and waiting at least 6 months after surgery is preferred. Treatment for salvage prostate includes 64 to 64.8 gray for negative margin disease, then the devil's number, 66.6 or 68.4 or 70.2 gray for positive margin or gross disease. An optional 45 gray whole pelvic RT would be favored if the PSA is greater than 0.34 or the lymph node risk is greater than or equal to 20%. You would give 0 to 18 months of ADT. Who benefits from ADT in the salvage prostate setting is controversial. The SIM would be wait at least 6 months after surgery for pelvic floor and continence to strengthen, possibly longer. SIM with supine, vac-lock, full bladder, empty rectum. Consider contrast to identify the anastomosis. You may not be able to maintain fluid in the bladder if the patient is incontinent. Penile clamp is an option, or wait even longer before starting radiation. The dose again is 64 to 64.8 to 70.2 gray. Whole pelvic RT to 45 gray is optional. Field, reference the original preoperative imaging for anatomic border reference, possible prostatomegaly and superior extent of seminal vesicles. Pathology may assist in areas to be more or less generous. Above the pubic symphysis, anterior border should be 1 centimeter into the bladder. You taper from the pubic symphysis. Superior border, if the seminal vesicles were involved, you want to do 3 to 4 centimeters above the pubic symphysis or perhaps bowel. May refer to pre-op staging imaging for seminal vesicle extent. If there's no seminal vesicle involvement, only 1 centimeter superior. Posterior border should be the rectal wall, the anterolateral rectum. The lateral border should be the pelvic wall. Below the pubic symphysis, the anterior border is the bottom 2/3 of the pubic symphysis, as long as it's at least 3 centimeters from the inferiormost portion and 1.5 centimeters of the neck included. Posterior border should be the rectal wall or the mesorectum. Inferior should be 5 to 12 millimeters below the vesicourethral anastomosis or above the penile bulb, if that's not seen. Lateral, levator ani, and the obturator internus. Chemo should be 6 to 24 months of ADT. Start adjuvantly. You might choose duration based on preoperative risk factors or current PSA level. Dosimetry, GU toxicity is best reduced by waiting longer after surgery, perhaps even longer than 6 months. In terms of the dosimetry, RTOG 0534 for the salvage prostate says rectum V65 less than 35%, V40 less than 55%, bladder minus the CTV V65 less than 50%, V40 less than 70%, variation acceptable, not meeting constraints is allowable on RTOG 0534. In coport, VA is V40 less than 77% and V65 less than 55%. Femoral heads, V50 less than 10%, and bowel, V45 less than 150 cc's. On RTOG 0534, entry was still allowed even if bladder constraints were violated. On coport, patient was no longer eligible for protocol if bladder constraints were not met. Timing, wait at least 6 months after surgery for pelvic floor incontinence to optimize. ADT can start prior to or at the time of radiation. Notes, while there is a biochemical progression-free survival benefit at low PSA, the establishment of biochemical progression-free survival as a primary endpoint is disputed. Overall survival in distant METs may be more appropriate. Biochemical progression-free survival is not a surrogate for overall survival or distant METs. The PSA doubling time of greater than 10 months has been shown to be a surrogate for overall survival. AUA guidelines suggest that greater than 0.2 as the cutoff indication for salvage prostate radiation. RTOG Sport allowed entry at greater than 0.1. Some other trials allow entry at greater than 0.2. SWOG and EURTC adjuvant studies, which included some salvage prostate, allowed even higher PSAs at entry. The EAU found that a PSA of greater than 0.5, Gleason 8 to 10, or PSA doubling time less than 1 year was associated with worse prostate cancer-specific mortality in a retrospective analysis that was also validated. Follow-up failure is PSA of 0.4. Phoenix definition is another possible option. Outcomes, the overall 5-year biochemical progression-free survival is 60%. 5-year biochemical progression-free survival 70% for those with a PSA of less than 0.2 in Cleveland. Radiation reduces distant METs, Loyola. Biochemical progression-free survival range is generally 50 to 80%. See Cleveland Clinic nomogram for distant MET rates and specific outcomes. Let's talk about brachy LDR alone. Those patients who are eligible for this are low risk or intermediate risk with only one risk factor. Contraindications are an AUA score worse than 12, a size greater than 50 to 60 cc's or less than 30 cc's, prior TURP, large median lobe, prior radiation or inflammatory bowel disease. Workup should be as above. Be sure to ask about prior TURP. Indications: the patient must be low risk or intermediate risk with only one risk factor. Absolute contraindications include high operative risk, no rectum, life expectancy less than 10 years, distant METs, ataxia, telangiectasia. Cautionary criteria include an IPSS of greater than 15 to 18, prior pelvic radiation, prior TURP, large median lobe, greater than 60 cc's, or inflammatory bowel disease. Treatment for iodine-125 should be 144 gray, and energy is 0.028 MeV, 60-day half-life. Palladium-103 to 125 gray, 17-day half-life, energy 0.021 MeV. The dose alone for LDR 144 gray for iodine-125, 125 gray for palladium-103. Field, I would first bring the patient to the clinic for transrectal ultrasound-guided volume study of the prostate. The patient would have had a bowel prep the night before. I would place the patient in the dorsal lithotomy position and prep and drape. I would then insert a Foley with aerated jelly. Using a transrectal ultrasound with ultrasound gel, I would take images every 1 millimeter. I would assess for pubic arch interference and record the angles of the probe at lengths once finished. I would use these images to create a pre-plan using a peripheral loading technique with a PTV of 3 millimeters laterally and 0 millimeters anteriorly and posteriorly. I would then take the patient to the OR and position the patient as done in the pre-plan with general anesthesia. I would prep and drape the patient, place the templates, and load the seeds according to the plan. Once finished, I would obtain AP and lateral orthogonal films in the OR to assess the placement of the seeds and would perform a rectal examination. I would have the patient return 1 month later for post-implant CT and dosimetry. No ADT for brachy alone. Dosimetry, normal peripheral loading, plan to 180 gray. Seattle V100 greater than 98%. D90 greater than 90%. Minimum, goal is about 130%. V150 less than 40 to 45. V200 less than 10 to 20. Urethral Dmax less than 110 to 120, some up to 150. Rectal D2 milliliters less than 100%. Calculation grid is less than 2 millimeters by 2 millimeters times axial slice width. Outcomes: RTOG 9805 multi-institutional trial of brachy showed 8% biochemical failure, 8-year overall survival of 88%, 8-year cause-specific survival of 100%, grade 3 GU toxicity of 3%. Acute urinary retention is seen in 10%. Brachy HDR alone, MRI, would be workup. This is performed in various risk groups, including low, intermediate, or high risk. Treatment should be 13.5 gray times 2 HDR. Dose: brachytherapy boost is 45 gray plus HDR, 9.5 to 11.5 times 2, 5.5 to 7.5 times 3, or 4 to 6 times 4. An LDR boost is 110 gray for iodine 125 and 90 to 100 gray for palladium 103. Adding brachytherapy to external beam results in superior biochemical progression. Free survival. There's no reported improvement in overall survival or distant METs, but toxicity is quadrupled. Node-positive prostate, 45 gray whole pelvis and common iliacs should be the treatment. 64 to 70 gray to the prostate bed, or 78 gray to the prostate with 54 to 70 gray to the nodes. Again, whole pelvic RT is 45 gray, nodes 54 to 70, prostate bed 64 to 70, prostate bed 78 to 80. Whole pelvic RT is common iliac starting at L4, L5, internal and external iliacs, presacral obturator nodes. Add an extra 7mm CTV margin around the vessels, then add 7 to 8mm PTV. PSMA mapping suggests that PA nodes should also be included, and also perirectal nodes. For chemo, they suggest 6 to 36 months of adjuvant ADT, guided by whether there is gross versus resected disease per practice or intermittent ADT. For prostate oligometastasis with 1 to 5 METs, there's a benefit in treating primary and METs in 1 to 5 METs. Definitive treatment to the prostate and the METs, intermittent ADT. Darolutamide plus ADT for PSA doubling time of less than 10 months. Castrate resistant, consider docetaxel. 3-year overall survival is 77%. 3-year biochemical failure is 25%. For prostate local failure after EBRT, the Phoenix failure is plus 2 nanograms per milliliter above the nadir. Confirm isolated local failure with imaging, CT abdomen pelvis, MRI bone scan, choline 11 or fluciclovine PET if available. I would biopsy the prostate, consider saturation biopsy of greater than 20 cores or an MRI guided biopsy. Calculate the PSA doubling time. You could treat with low dose rate iodine 125 to 140 gray or palladium 103 to 120 gray. HDR, you consider SBRT 34 gray and 5 fractions. Other options include ADT or radical prostatectomy and pelvic lymph node dissection. You could do intermittent or continuous ADT at PSA greater than 5, then switch to intermittent when PSA is less than 4. For NCCN, you can start ADT if the PSA doubling time is less than 12 months, but should individualize decision based on the individuals. 14% late grade 3 adverse events with LDR, higher V100 predicted late events.